looking at the MMC for infrastructure. You are not acting for the MMC for health. Okay, you are no longer acting this week. I want to acknowledge all the media people who are here, and some of the media people are our NGO friends who are doing a lot of work from the civil society perspective, also in monitoring how Gauteng government is responding together with the rest of society to COVID-19. I first want to outline, we're going to have basically, first presentation will be on COVID-19 preparations, assessments, risks for the second surge or the second wave. This is the modeling team of the province that has a team of scientists, social scientists, as well as epidemiologists and health specialists. They advise the provincial government, working in conjunction with the Ministerial Advisory Committee that advises the Minister of Health. They work on looking at data and trends in Gauteng province. So Professor Bruce Melado is going to do that. Just look at the trend, where we are coming from in Gauteng, what is data saying, and what are the things that we must watch very closely, and right at institutional level, at societal level, and government-wide. What is it in Gauteng we should be doing? This will be followed by a presentation, basically, that would not be long, a brief presentation on some of the infrastructure interventions, repurposing, including additional infrastructure capacity we have been doing across the province. And after those two, just at 12 o'clock, I will come back and give you an update on issues pertaining to SIU investigations into irregular procurement of PPE. I'll do that at 12 o'clock. So let me quickly give way to Professor Bruce Melado to talk about the modeling, that the numbers that they are watching and what those numbers are telling us and what we should be doing in Gauteng. Professor Bruce Melado.
Thanks for having me, Premier. So as the Premier indicated, we're going to go through the status of the modeling, and in particular, we're going to be talking about the risk of a second surge in the province, taking into account data from all over the world. These activities are supported by the Gauteng Province Department of Health, the Department of Science and Innovation, the NRF, Wits University, in collaboration with the GCRO, IBM, and funding from the IEEE. So this graph here, the upper graph gives you the daily increase of cases in the province. You can see, you can look at it on a daily basis on the website out there. You can see that around June we had a strong increase that was stopped due to a number of circumstances that are now understood. The number of cases went down to somehow stabilize at a level that I will be commenting on in a minute. You can look at the lower graph, which is basically giving you the number of cases on a weekly basis, where around the peak of the first surge, we had around 35,000 cases. Right now, we are at a lower level, significantly lower, around 2,000, with an average of around 300 cases per day. It's very important to underline that the structure you see in the data is not representative of the peak of the pandemic. This is the peak of a surge. And as we are now learning, the pandemic will have more than one surges till we have a vaccine, an effective vaccine, or the number of susceptible people becomes very, very small. So as you can see, we have certainly declined in terms of the number of cases. However, as you will see in a minute, while low, and that clearly is a good thing, is not sufficiently low so as to prevent a second surge. Now, before I get to that, I'll give you a few words about the status of the modeling here. Modeling is something that has to be recalibrated continuously. It's not something that is God-given. It's not something that is given to us by a bunch of very smart scientists. It's something that is that needs to be adapted to the data. So what we do first is we apply artificial intelligence on the data in order to identify the hotspots. Hotspots are small pandemics that need to be removed to understand the average behavior of the pandemic across the province. Once after you do that, you are able to look at transmission rates and other epidemiological parameters for the province. In level 3, around July, August, you can see that the transmission rate, or the speed with which you get new transmissions or new cases, was significantly dropping. There was a very strong drop that led later to level 2, which is around August till the end of September, where the transmission rate continued to decrease, but now the deceleration is leveling off. The number of cases basically levels off, and that's what we are essentially today. So all these numbers, all this data basically comes in to feed into the models to provide new predictions. As I said earlier, our predictions are continuously adjusted, continuously recalibrated to accommodate best the reality on the ground. Now, that being said, it's now essential, as the Premier already indicated, to establish a metric of the likelihood of a second surge. The creation of a second surge is the result of many complicated parameters and factors, and it has to do fundamentally because of the fact that we have a significant number of transmissions happening in large swaths of territory in a way that is random. So the probability of these leading to hotspots and those to more hotspots is certainly very high. Our job is to basically create a mechanism, an algorithm that provides a probability of that thing happening. The characteristics of the second surge is the role of the modeling, and that is what the modeling is going to do. The risk index that we have developed for the province has the job of telling policymakers in the population when something is going to happen. Now, in order to illustrate the importance of being alert, let's look at the daily cases in Spain. So if you remember, Spain experienced a very fast growth around the first half of March, leading to a peak, which, as we know it now, was not the peak of the pandemic, was the peak of the first surge. The number of cases went down as hard lockdown measures were implemented, and Spain, around May to June, stabilized at a relatively low number of cases. Just to give you a measure, we're talking about 200 to 300 cases a day. Now, this needs to be compared to what we have in South Africa today, which is about 1,500, which is significantly larger than the minimum amount of cases that Spain stabilized at around June, July. Okay? That being said, despite the low number of cases, because transmissions happen more or less randomly in very large swaths of territory, the second surge happened, in fact, with a significantly larger number of cases, although mortality, of course, significantly less. Another important case, and we're not showing this just to say this happened in Spain, ergo, or therefore is going to happen here. This has happened in many countries. The case of France is particularly important for modeling. You can see that there was the peak of the first surge, not of the pandemic. France stabilized around 300 to 500 cases, significantly lower than South Africa, but now it's in the middle of a surge, of a second surge, which is way, way bigger than the first. Yet the mortality indeed is lower, but yet the number of positive cases has dwarfed the first one. So this basically tells you that yes, under certain circumstances we can stop the pandemic in its tracks, but that is the result of the action of government and the population altogether. But that does not mean that the pandemic is over. It means that at some point, due to a number of circumstances, a second and a third search can take place. In some countries or states in the United States, they are now undergoing even the third search. As a result of that, we have developed a risk index. A risk index is not telling you what will be the specifics of the second or third search. That's the role of modeling, which we also provide to the Office of the Premier. But it's a number that basically quantifies whether we need to get worried about the advent of a second or a third search. Essentially what happens is that you define a threshold above which, if the index is higher than that, the probability of a second search is very high. It's typically about 80%. 80% is extremely high, very close to 100%. And typically what happens once you pass that threshold, the second search, or the following search, if you wish, happens around within 4 weeks. That, of course, is the result of generalizing and putting together data worldwide. So you need to look at this risk index and monitor it very closely on a daily basis as an algorithm for early detection of the second search. So we've created a website that you can see right there. You have a link there. You can click. There's an interactive map of the risk indexes for all the provinces of South Africa, where the risk index pertaining to medium risk is about 7.5. It will be readjusted with more data, but it will not change significantly. And the risk index above which the probability of a second search becomes quite large. As I said, 80% is 10. And as I already indicated, the time that it takes roughly for the second search to occur after the threshold has been reached is about 4 weeks. This website is updated daily, and we encourage everyone to look at it as of that. Gives you the risk index for the Gauteng province as a whole in the average in relation to the medium risk and high risk. So you can see that we are still way below 5, which is a good sign in that things are under control, but what we have to be cognizant about is that the index is continuously growing. This is the result of the fact that the numbers are not going down and down and down. They're basically stable, and that is a source of concern. So we have to look at it very, very carefully. We also have the risk index for the different districts, and we are also developing risk indexes at a more granular level in the province. So the bottom line here, it is very important to monitor. Monitoring now is essential to understand when the second wave is going to take place. Okay, so this brings us to the summary. So we have 3 clearly stated punchlines here. The first thing is what we have experienced in South Africa and elsewhere is not the peak of the pandemic, but the first surge. Okay, because the fact of the matter is that most of the population remains susceptible, and the danger for further surges is very, very high. As a result of that, we should not let our guard down. That's the bottom line and the main message that we want to convey to the population. We have developed now a risk index. That's a number that helps the population and policymakers assess the level of danger of a second surge, and that is available on our website, and it is updated on a daily basis. And while the risk index of Gauteng still is low, is below 5, which is certainly good, however, monitoring is critical in this situation. Thank you very much. Thanks, Fred.
Yeah, I think now we will move to the health report. We'll start with the acting HOD, Malotana, and then the MEC for infrastructure development will speak about the infrastructure projects.
Thanks, Premier, MECs, MMC and colleagues. I'll once again run us through this weekly pandemic report, just as an update of where we've been as a department in terms of our response to the pandemic. As usual, Gauteng had a 6-pillar strategy in terms of the response to COVID, and I'll be responding or talking to the comprehensive health part of the presentation. As far as the figures are confirmed, I think this is a national picture in terms of the number of infections that the Prof also made reference to, 689,000 cases. What's important in this slide is the number of recoveries that are almost equal to the number of active cases, at 618,000. Of course, unfortunately, the 17,000 deaths that have since succumbed, and of course, the new cases 1,700. And I think the number, for those that have been following this, the weekly briefing, the number has come down quite a while. Of course, Gauteng remains the epicenter in the country with the highest number of infections as we've previously articulated. In terms of number of confirmed cases, Gauteng, of course, still has the most number of confirmed cases relative to the rest of the country, of course, followed by KZN. We contribute 32% of the total number of cases, and of course, importantly, so we also contribute the highest number of recoveries nationally. As far as number of recoveries and deaths, of course, we've got up to, as we said, we are contributing 32% of those total number of active cases, as far as it relates to the number of deaths, of course, with our percentage of 4,386 relative to the total number of deaths that we have recorded nationally is 25%. In terms of cases, as at the 8th, this really slides is just a summary of trying to demonstrate number of recoveries, active cases, and number of deaths. Our total death recorded to date still makes 1.9% against the total population of active cases. I think what's important for tracking purposes is this number of positive cases over a period, and I think we are quite familiar with where we come from level lockdown, level 5, 4, 3, 2, and 1, and what's particular interest for us now in the past 8 to 10 days is the number of infections since we got to level 1. They remain relatively stable. There was a slight spike that from a public health point of view we will have considered it rather insignificant, but it's something that we are watching closely. As the Prof indicated, we are cognizant of the potential for a second wave, and everything else we do, including the part of the infrastructure planning that the Premier and the MEC for DID will talk to, relates to that. This is really a demonstration of average daily infections, and I think if you look to the bottom right of the screen, you'll see that the number of infections have since come down quite a lot, and it's something that particularly we want to pay close attention to. In terms of the regional breakdowns, also one thing of the biggest thing we've been able to do is to be able to track number of infection, positive, recovered, and active cases at the district level, and of course at the sub-district level. Johannesburg has always been from day one the number of highest number of infections with 42%, followed by Ekurhuleni and Tshwane, and of course the balance of the district municipality having those. Johannesburg has got the highest number of infections, death, active cases, and of course, as the biggest contributor. Particular interest, of course, the Region D in Johannesburg, which includes part of where we are in Soweto in terms of the number of active cases. Of course, this is not in isolation. If you look in Tshwane, the CBD, the Lodium part of town, also it's a cause for concern. So really the reflection is that the virus is quite all over the province. There is no area that is not necessarily affected, although our day-to-day interest is about where there are spikes, we get to the source and we try and actually contain. These are the further details that I will have provided. At the sub-districts with the highest number of active cases, you will see all of us that live in Gauteng can find ourselves in terms of where we live and see the number of active cases within our precinct or our locality. In terms of the 7-day increase per sub-district, I think one particular interest is the issue I've raised. There has been a slight spike that arose from the area in Tshwane within the CBD at 225, of course also in the city of Johannesburg at 140. But relative to where we come from, in the current rate of infection, I think as a province we are quite comfortable, provided everybody else continues to adhere to the protocols that are in place as far as how we should be managing, including the sanitization and social distancing. As far as related to the number of deaths, our death rate, as I said, they contribute to 1.9% of the total cases as far as related to the province. with 4,386. What's important about the number of deaths is that, of course, the deaths are spread across different age groups. And then, of course, the next slides will also reflect that where the deaths are occurring, also there's also a degree of an underlying condition. They are generally mostly not in isolation. Really, this is exactly what happens. That, of course, most of our patients that arrive at a facility, they seem, of course, if they are going, the 55% of patients that we have treated have demised within the first week of admission, and of course, then beyond that, the recovery rate seems to be to improve quite relatively. In fact, the average admission rate for COVID patient with underlying condition is 41 days. And that's the breakdown in terms of the underlying conditions, where they are known and where they are not known. What's important about the NHLS screening and testing slide is to demonstrate, one, that despite the level of infections, we continue to do daily tests that will continue to be done. In fact, at some point, the testing has slightly increased relative to where we come from. But also important is that the number of tests that have been done nationally, Gauteng does the most number of tests at 33% of the total number of tests that NHLS performs in the country. As far as the bed availability, and this part of the detailed breakdown that the MEC for DID will get into the specifics, but importantly so, is just to demonstrate that we've created a number of beds and capacity at different levels of care: adult general beds, pediatric beds, high care beds, and of course the field hospitals that was created at Nasrec with a capacity of 1,000. And the breakdown in terms, of course, what's important about the slides, it's also cumulative demonstration of the number of beds that both the province and the private health sector had been able to create. Over 10,000 beds available for COVID. But it's important also equally that maybe at the next slide is that at the peak in July, we had over, at a particular time, we had just over 5,000 patients admitted through the system, and there was no point in the particular time where we ran out of beds for the admission of this patient as a province collectively. But as things stand now, the number of patients that are currently admitted at 1,870, most of those patients, of course, remaining in public health services at 1,018, and the breakdown in terms of their condition. What's reassuring is that most of the patients that are within our facilities remain quite stable on room air or with passive care rather than active care. Of course, there are ventilated patients that are in the system, but the number is quite low relative to total number of infection or patients that we have. As far as relates to hospitalization, of course, what's important about that slide, that at some point we're hospitalizing, and that's the point I was trying to make, 7,193 at the 15th of July, and as things stand now with 1,800, you can see that drastically the number of beds that are available there vis-a-vis the number of admission. It's also a reflection of how the province has been able to respond to the pandemic, but also the capacity and the resilience of the public health system to manage some of these patients. Of course, health professionals are not immune, including public servants in this instance. So relatively, there has been public servants, over 10,000 that have since tested positive, and of course, those including educators, as you know, the schools have since reopened. But probably the parting message I would want to leave the colleagues today is that, of course, despite the level of regulations we find ourselves, we must continue to adhere to WHO guidelines as far as it relates, one, for the treatment regimes, but secondly, in terms of the protocols of how we should be socially behaving on our day-to-day. Of course, there's repurposing of the COVID-19 beds, given the number of patients that we are dealing with, as we reopened the health system to be able to provide comprehensive health services. Some of those beds that remain underutilized with the current, we are repurposing them so that we can continue to provide comprehensive health services. I'll rather stop here, and then, because the next part of the presentation will be the detailed infrastructure capacity, but just safe to say, there has been some quite of investments in terms of the number of beds we've created in the system, and we continue to do so. In terms of the additional beds we've been able to create at 1,881, and of course there was since appointed just under 2,000 personnel just for the purpose of COVID alone. And one of the things we don't take away is that, of course, we're coming from a low base. The number of health practitioners required for the health system is not enough, but I think this is just a demonstration of the amount of work that is gone into. And of course, the next speaker will go into details about the investment that we've made as a province in health technology and infrastructure. Thanks, John.
Okay, MEC Mutara will continue with the specific of the infrastructure projects.
Thank you very much. Good morning, colleagues, Premier MEC and senior officials from the Department of Health and DID. I think importantly is our story around why we did what we did, where did we start, what are we doing currently, and what is it that we're going to do in the future. We've shared with you the gap analysis, but in terms of the break up between the critical care beds and the general ward beds, as of at 30th of June, we had no gap between the critical care as well as the general ward beds. However, when we looked at the capacity as we were going towards the peak, at the time, which our peak was expected to be in September, the capacity that we started with from the 1st of June, had we just kept the capacity as it was, we would have had a gap in the critical care as well as the general ward beds by the end of July of 410 as well as 1,091 respectively. And by the time we would have reached our peak, which is what the modeling was telling us when we looked at our capacity at the 1st of June, was that by the time we reached September 2027 would have been the gap we had in critical care beds, but we would have had a gap of general ward beds of 5,948. So when we looked at what we had and what we had in terms of capacity and using where we were expecting the peak, that was the story that we were being told, and we had to respond in order to make sure that we had no gap at the end of July and no gap by the time we reached our peak. Of course, then the modeling changed and the peaks, we reached our peak in July. We adopted as Gauteng Province the following pillars to be able to respond to the bed capacity for COVID-19, but also beyond. We started with looking at what our 5-year infrastructure plan was, and we needed to be able to not lose the 5-year infrastructure plan, but be able to respond to COVID, making sure that we also integrate our plans according to what our 5-year plan was. So importantly was we needed to create critical care beds and general beds in our current capacity, which was looking at all 32 hospitals, and then to reconfigure that space. And we selected 10 hospitals across the 4 management clusters to do this. Of course, when I say we, it's the Department of Health who was leading that process. We also then, so our first key aspect of what we wanted to do was to be able to invest in our own facilities so that beyond COVID, we have the capacity in our facilities and they can be used for whatever health needs and health pressures there would be in the future. We recommissioned and reconfigured the Anglo Gold Ashanti, which was a donation by the Anglo Gold company, to be able to respond to critical care hospital to create 175 high care beds, and that would service the western corridor of the province where we know that we don't have adequate capacity. The construction of new facilities, and we also aligned with our 5-year infrastructure plan, selected the 4 hospitals where we are currently busy doing work, and that is the Bara Hospital where we are today, the Dr. George Mukhari Academic, Jubilee Hospital, as well as the Kopanong Hospital. And the reason also for that selection was looking at our 5-year plan on infrastructure, where we are, where we want to be, and how this additional capacity will look towards adding additional capacity at the hospital, but also looking at the upgrades and future plans that we have for these 4 hospitals. Our out-of-hospital temporary facility, as a province, we were very adverse to that, and we only selected one site to do that with, and that was the Nasrec Center. What we did there was 500 isolation and quarantine beds, as well as 1,000 P3 beds to isolate non-critical patients outside of hospital environments. And then importantly was also to maintain and operate facilities provided to us by state-owned enterprises. And there we have Telkom, Eskom, as well as Transnet, who gave us those, and we maintain and operate those facilities. What are our long-term benefits accrued from our own COVID response program? Well, I've spoken to being able to align the 5-year infrastructure plan that we've had as a province, and looking at the opportunity that COVID provided for us to bring some of those plans forward. The reconfiguration brought forward the critical upgrades that we were planning, and we used this opportunity to be able to do that, and all our infrastructure upgrades has used the IUSS standards for compliance. The ABT beds can be used as independent hospitals. It can be used as part of existing. It can also serve as decanting wards for the planned refurbishment of the OHS program. And in the Premier's State of the Province address, he would have spoken about the priority hospitals. These cover the priority hospitals, but also would have spoken about how we need to upgrade all hospital facilities. We're prioritizing 10. For the first, we were supposed to have prioritized 10 for the first, in the first phase. So we used this opportunity to be able to bring forward what we had planned in terms of the OHS refurbishment program. So the construction of the 300 high care beds using the ABT or the alternative building technology does cost less than conventional construction methods. What usually takes us 36 months to build in what we refer to as a CHC, which is a clinic, it took us between 6 to 12 months to complete a 300 high care bed using the alternative building technology. And this is why we had chosen to go the route of ABT, because of the time as well as the cost that it was giving to us as a benefit. We could have, if we were still running the same five-year program, we would have used the normal, the conventional methodologies to be able to deliver on the 5-year infrastructure program. So for us, importantly now where we are is that the facilities are going to be equipped with what we refer to as functional beds, and that includes the designated bed provided with relevant and adequate healthcare professionals, beds that are equipped with relevant and adequate healthcare technology and equipment, and that is aligned to the level of care that is assigned to those beds. And then it must be, of course, provided with support services such as cleaning, catering, etc. And for that purpose, funding for the health technology as well as human resources was also provided to operationalize beds that became available along through construction, through the construction activities and even going forward. And Dr. Molotana spoke, Mr. Molotana spoke about that. This is just a pictorial representation of where we are in terms of how we've reconfigured the general beds, high care and ICU, which facility. So it's quite colorful, but the colors depict on the map in terms of each facility. So like I said, we chose the 4 hospitals for ABT, and then we had the additional hospitals where there were also ABT as well as the in-hospital reconfiguration. This just gives us a breakdown of where this has taken place, and the number of beds and the type of beds per facility. Of course, what we had planned in the general types, the general bed type, we had planned 1,282, we've completed 1,260, and the ICU high care bed, the planned was 2,140, and we've completed 621. The quarantine, we planned 500 and completed all 500. The new hospital infrastructure, which is the ICU and high care bed, the planned was 1,400 in the 4 hospitals combined. To date, completed, we are saying that there are 0 completed because they are not functional as they should be. Today, 100 at the Bara facility will be handed over to health for the Department of Health to be able to equip, furnish, and bring them operational. So let me speak about some of the challenges that we experienced, and it's important to be able to complete why we are where we are in terms of chasing the peak, which was what we were essentially trying to do. Importantly was that most of our projects, barring the ABT, started under lockdown level 5 regulations. That meant that we had constraints in terms of material, in terms of construction companies that could be operational, as well as laborers that could work on site. We had to negotiate with with the various hospitals to be able to accommodate laborers to stay at facilities, as well as to put in 2 shifts per day to be able to respond to the chase. The availability of suppliers and materials became a major challenge. A lot of factories were closed at the time. Of course, it then eased up as we got to lockdown level 4 and lockdown level 3, respectively. We also had what is very common in our sites, which is site disruptions, especially by local SMMEs, as we moved from lockdown level 3 to lockdown level 1, where we had more and more activity and people being able to move around. The target dates that we set by the department was also impacted by a number of factors on the ground, which are of a technical nature. Where we are currently, we faced such peculiarities such as hard rock, dolomite, and where we had to do deep excavations. And then, of course, the availability of long lead items. And the long lead items are a very critical component of what would make these beds functional, and that's your HVAC units, generators, medical gas. Some of our suppliers even had COVID outbreaks at their facility, had to shut down. We also had COVID outbreak at one of our construction sites and had to close the site for about 2 weeks for us to respond with all the necessary protocols. We also had issues of clearance of imported material at the port of entry, especially around the ABT and the HVAC. A lot of those materials, unfortunately, and that what COVID has presented is the fact that we still rely on a lot of imported materials as opposed to locally manufactured. They are locally assembled. And I spoke to the COVID outbreak that we had on one of our sites, and as well as power disruptions at supplier facilities. That really affected us a lot in the Ekurhuleni area, where we rely on many of the manufacturers to supply us with material. Here we just have added some of the pictures of the Chris Hani Bara, which we still will have an opportunity to look at. And this is the alternative building technology sites. And that is just to give a demonstration of where we started and the indication of the deep rock excavations. And that is then the end of where we are in terms of the story of infrastructure. We are going to work with the clinicians and each facility to be able to have discussions about the future use in response to the pressure that the healthcare system as a whole in the province faces, but also as we move towards NHI, as well as realigning and bringing back online all our projects and program in line with the 5-year Growing Gauteng Together 2030 strategy. Thank you very much.
All right, thank you, MEC Mutara. The Premier will now come and give us his concluding remarks.
Thank you very much, Thabo, and to the colleagues who presented. Firstly, just to go back to what the modeling says, that the risk for a second surge is still staring us in our faces, and we should never be complacent. And my message to the people of our province, I went to the townships last week, and I spoke to a lot of people who were not wearing their masks. And I asked them, why are you not wearing? People have their masks with them. They put them in their pockets. Prof, they have their masks, but they are not wearing them. I was in Tembisa, basically, when I approach people, and then I say, why are you not wearing your mask? They take it out of the pocket and then put it on. And in conversation, they think COVID is gone. So the first message from our modeling team is that we must continue to be vigilant. We must continue to observe all the measures. We must continue to wear our masks. We must continue to sanitize. We must continue to social distance. Even when we have to examine the facilities here, we should do that. One of the reasons we decided to come to Chris Hani Baragwanath, and we are going to all our facilities. So every week we will be visiting our facilities. We are checking, we are getting experience from the clinicians. How did you cope during the peak of July? This morning we got a report from the leadership of Chris Hani Baragwanath and the clinicians about how they repurposed some of the wards and what more work needs to be done. We want to continue to work with the health professionals, especially our clinicians, to be the ones who direct us. Where we are investing in infrastructure, what is the most useful way for now and in future? And that's why all this infrastructure that is there must always be purposed and repurposed to meet the needs of healthcare, the needs of our people, but those needs are best explained and defined by the healthcare workers. I want to assure the people of our province that where we have put in infrastructure, and let me just say to you, by the end of this year, we would have brought in 3,422 new beds that did not exist before COVID. So all the repurposing we are doing inside our hospitals and additional capacity we are building, where we are putting up new capacity, by the end of this year, we would have added 3,422 additional beds that did not. In March this year, those beds would have not been there. Of course, the beds don't go alone. They go with the healthcare, the human resource. Again, the feedback we got this morning is that there's lots of pressure on our healthcare workers, that as we add more beds, as we bring in new technology, we have got significant new technology that will help to save life. Some of that technology, you see it in boxes here this morning. The CEO was saying to me, this is new technology that we dearly need. Professor Rudo Matiba was saying this technology will help us. We are an old hospital. It will help us even with the old wards, that they will have better technology. We shouldn't just look at the new areas. But we do want to say we are committed to building that Lilian Ngoyi District Hospital. We are committed to the upgrades of the old hospitals, but we don't want to rush to the new and abandon that which works. So Chris Hani Baragwanath is a center of excellence in Africa. It is here where the battle against COVID was fought. And lots of lives, yes, we lost 500 lives right here at Chris Hani Baragwanath, but we saved many, many, many lives, thanks to the healthcare workers. And so when we do infrastructure, it must always be in response to what your needs are, because we must be guided by you. It mustn't just be you, it must be guided by you. So 3,422 new beds is what we would add. We may have done it differently. We resisted the pressure to just put up many hospitals all over Gauteng. We said we are bringing the numbers into our existing hospitals. I really don't want to take off my mask, but it is just for, I really want to I don't want to speak without my mask. So if I keep pulling it up, bear with me, because I'm also talking to the people of Tembisa. When I was saying to them, where is your mask? I must have my mask on all the time. The last issue I want to speak to is, as we do all this, as we were responding to COVID, our province did very well. There was a period where we were really doing very well. But there is something that happened that really, it put a terrible blot on the great work that we were doing. That is PPE corruption. And I know that this impacts on the morale of the health workers who have been doing great work on the ground, who have been taking tremendous risks. This impact on frontline workers who have been risking coming from level 5, who have been working right up to now. So corruption, PPE corruption, has had a negative impact on the great work that our province has done. And I must say that often when we talk about this PPE corruption, we often forget that the Gauteng healthcare workers, Gauteng institutions, the Gauteng Provincial Government, working with other agencies and civil society, put up a brave fight. But those who saw PPE and COVID-19 as opportunities to enrich themselves, have done a great disservice. And that's why I always want to say, we will leave no stone unturned. Every act of corruption or collusion that took place in the midst of fighting a terrible enemy, merciless enemy, it is time that people must be put to jail. I want to emphasize, everyone found to have been corrupt in the midst of a difficult fight against an invisible enemy, in the midst of great, tremendous risks taken by ordinary people, and in the midst of a battle where some lost their lives in our country. Action has to be taken. Of course, action has to be taken based on evidence, on investigations, and there must be consequences. You already know that so far there are several officials in the Gauteng Department of Health who have either been suspended, some have resigned. Others have been suspended or they've resigned because they clearly did things that are wrong. They must answer for those. Others is because they didn't take enough action. That's what the investigations would be saying, that those who with authority could have done more and they didn't. Others is because they did things that are clearly wrong. I want to emphasize that we want the money back. We want to retrieve the money. We want the money back lost to PPE corruption. And any act of corruption anywhere in the course of our response to COVID-19 and any other area of government. So where there's corruption, there must be firm action. So I have been receiving reports from the Special Investigation Unit on a weekly basis about the investigations they are conducting. Every time they give me a report, there's an identified area of action, and action has to be taken. Sometimes the decisions have to be made by the relevant executive authority. It may be an MEC or an acting MEC. If it is the premier, I take that action. It may be a head of department who must suspend an official. But action must also be taken against the businesses, the private sector businesses that clearly colluded with government officials in this act of corruption. So we have acted on a number of. One report, as the Premier of the province, I've particularly been keen to receive, is to know whether my colleague, Dr. Bandile Masuku, the MEC for Health, was involved in any acts of collusion or acts of corruption. This is a report I've been keen to get from the special investigation. I've keenly been awaiting for this report. Last week, Friday, that is on the 2nd of October, I received the latest update from the Special Investigating Unit on the matter pertaining to the role of the Health MEC in the PPE procurement in Gauteng Province. It is a matter of record that on the 30th of July, I placed the MEC on special leave and appointed an acting MEC. I today, therefore, report to the people of Gauteng I want the mask always on. The mask must always be on. Today, I report back to the people of Gauteng on the findings of the SIU and their recommendations, and therefore the decision that I would have taken coming from that. So the SIU has found that the Health MEC, Dr. Bandile Masuku, has failed to execute his functions in compliance with the Constitution and the Public Finance Management Act. I want to repeat. The SIU has found that Health MEC, Dr. Bandile Masuku, has failed to execute his functions in compliance with the Constitution and the Public Finance Management Act, the PFMA. Based on this finding, they then recommended that the Premier of the province should take administrative action against the MEC for the purpose of determining the suitability to hold office as the responsible MEC for health. With regard to the substantive public interest issue of whether the MEC was involved in acts of corruption or collusion, the SIU reported to me that this investigation is ongoing. I've said to you what is it that they have found, but I was also very, very keen to say on the substantive matter of public interest of PPE corruption. The SIU has reported to me that their investigation on this part of the work is ongoing. And this investigation will hopefully be concluded and the facts be established as soon as possible. Because as the Premier of the province, I want the facts about whether the MEC was involved in acts of corruption or collusion. I want those facts because it's a matter of grave concern relating to clean governance, which is a pillar of what we have been trying to do in this province for a long time. So just based on the first thing I said, based on their finding, where they say that the MEC has failed to execute his functions in compliance with the Constitution and the PFMA, I have decided as the Premier of the province to discharge Dr. Bandile Masuku from his responsibilities as the Gauteng MEC for Health. I have taken into cognizance the contribution that MEC Masuku played in improving the Department of Health since his appointment last year in May 2019, and the leadership that he provided during COVID-19 in this province is something that is undisputable. But there are issues before me as the head of the provincial government based on the SIU report that I must act on. And it is on that basis that I have decided to discharge MEC Masuku as the MEC responsible for health in our province. Taking into account that there's the part of the SIU report that is still outstanding. They've given me one part of the report, and they've said they are still completing the investigation on acts of corruption or collusion. I will not fill this vacancy for the MEC for Health until they have submitted the final report. So MEC Mamabulo will continue as the acting MEC for Health until I have received the final report of the SIU as it pertains to those issues about the acts of collusion and corruption, which they say is an investigation that is ongoing. I do want to know and get this completed before I appoint the MEC for Health in Gauteng, because I want to say, should MEC Masuku be cleared, I will gladly reappoint him as the MEC for Health. Should he be cleared, I will gladly reappoint him as the MEC for Health. But as things go at the moment, that's part of the investigation that is continuing. And I want to say that corruption is a very, very serious matter, that as a country, we have to send a strong message that where corruption is established and it's determined, there must be consequences. At this stage, as it pertains to the part of the investigation about corruption, that part will hopefully be concluded as soon as possible. So I keenly await the final determination of the SIU pertaining to allegations of corruption and collusion, but I am acting on the part where they say he has failed. I am acting on that part already. I want to also conclude by saying I further asked the Minister of Health, Dr. Zweli Mkhize, for a reinforcement. This is critical time. The risk for a surge is always there, staring us in our faces. Due to the several suspensions and resignations in the Department of Health, because of the ongoing SIU investigation, I have asked Minister Zweli Mkhize to reinforce. This is a request I made in June. Some of you, the CEO, may remember that in June we were here, Prof. Matiba, we were here in June with Minister Mkhize to hand over the ventilators, donations from the US. In June, I had requested, in anticipation of the surge happening, and continue to say to the minister, we will ask you for reinforcement when the situation becomes difficult. Now I have activated that in writing to say, Minister, we have several officials who we have suspended because of the investigation of the SIU in the department. We don't want the department to remain with too few senior officials so that its response to COVID-19, should the surge be in our face in a few weeks or a month or so ahead, we must have the full capacity to respond. So I am awaiting, the minister has reassured me that he will consider this reinforcement. We do have senior officials in the Department of Health. We have very capable people on the ground, especially managing our wards, very capable clinicians. We've got a lot of capable CEOs. Many of them are new CEOs, recently appointed to fill the vacancies. They are the ones who are running our healthcare system. We've got lots of workers who are maintaining our hospitals, making sure that the hospitals are clean, patients are attended to. but the head office of the Department of Health in the province has to be reinforced. And that's what I have asked Minister Zweli Mkhize to do as we continue with the investigation into PPE corruption, because this investigation is continuing and it may take much longer. And we don't know which other officials may be found to be wrong. So, in conclusion, we will continue to work with the people of our province in communities. We must all join hands in combating COVID-19. Our leaders of our hospitals, the CEOs, many of them are here from different hospitals. We want to continue to urge you to continue focusing on the battle. The battle is to save lives, to combat the surge is something we must really, really avoid. Let's continue the battle. We must continue to provide capacity to you, additional PPE of good quality, because one of the lessons we have learned, this PPE corruption, coming from feedback is from workers themselves, is that some of the PPE was of poor quality. Poor quality PPE is not very good. It can't help us in the fight against COVID. The distribution of PPE at all times in our hospitals is something that is receiving attention from the acting MEC for Health, working with the team at the provincial level. I want to say, let us continue as Gauteng Province to fight this battle. At the same time that we are focusing on the real enemy, COVID-19, we must also battle other twin enemies. Corruption is a very key enemy in the battle to transform our country and build a better life. Gender-based violence is a very, very real enemy, particularly during COVID-19. Women have been on the, we saw the number of women, especially in July, the number of women who were getting infected with COVID-19, those numbers were rising. At the same time that they are at the cold face of violence, gender-based violence perpetrated by men. So we need to fight these battles with the same determination, because if we want to ensure our health system responds to challenges, today is COVID-19. There may be another pandemic after COVID-19. What lessons would we have drawn? Would we have built enduring capacity, more human resources, more health infrastructure and better health infrastructure? Would we have done that? But would we have also drawn lessons that wrongdoing, when you want to do some in the course of fighting pandemics, we must be intolerant to wrongdoing, particularly corruption. There may be wrongdoing about mistakes. Human beings can commit mistakes. Someone did not do something that they were supposed to do. But we must be totally intolerant of corruption. And I know sometimes our senior healthcare workers and our senior managers, including at head office, sometimes they act feeling that if you commit a mistake, you might be lumped together with those who are corrupt. I know the senior managers in the health headquarters, people who are very well-meaning. And I'm not talking about, there are crooks and there are those who are very well-meaning. I know they have been worried and shaken that even if they do things in the best interest and commit mistakes, they will be conflated with the corrupt. No, I want to assure you that you may commit mistakes. We are able to separate corruption from wrong judgments, arriving at a decision that was wrong, which may have had other consequences, cannot be conflated with corruption. Corruption must be dealt with where you have people who have systematically and deliberately sought to benefit themselves, their friends, and their families from the resources that are supposed to face life. That we must be intolerant of and we must fight it with the same determination. So thank you so much. We are at Chris Hani Baragwanath today. We will be going to the next hospital. We will go to all the hospitals, especially those 10 hospitals we identified in the State of the Province address and said we need to upgrade them, we need to improve them, we need to improve and refurbish them. We also need to build new facilities. We will go to all those. So thank you so much.
Thank you very much, Premier. We will now take questions. Can the mic move over there? I see Griselda. Okay, let's start there. Yeah. Please just introduce yourself.
Thank you very much. Griselda Lewis from SABC Television News. Premier, I would just like to find out, when you informed Dr. Bandile Masuku that he was being relieved of his duties, as you say, what was his response to that? I understand that he may have felt that the SIU had not properly ventilated the issues pertaining to the decision which you have subsequently come to. And there's another report that has been released by forensic investigator Paul O'Sullivan, which seems to clear Dr. Bandile Masuku of knowing anything about Royal Baqa's involvement within the Gauteng Department of Health. I would like your response to that. And do you fear perhaps that the MEC, the former MEC, could use that report to challenge the decision that you have made? Thank you.
Okay.
Okay. Hi, Premier. Sipa Kema from Newsroom Africa. Premier, I just need clarity on when you said that should the pending investigation, the SIU investigation on MEC Bandile Masuku's involvement, clear him, he'll be reinstated. But then the findings that you gave us now, of course, say that he failed to adhere to the PFMA. Those findings still stand. So why reinstate him?
Okay. Yeah.
Thank you so much. It's Govin Whittles from ENCA. Premier, what exactly does the SIU say MEC Masuku did that contravened the PFMA? And how exactly did he act in contravention of the Constitution? Why consider bringing him back then, sir, to add to that question as well? No, thank you.
Okay. Yeah. Right at the back. Yeah. Yes.
Premier, thank you. Mark Hayward from Daily Maverick. Premier, do you have any concerns about corruption in relation to the health infrastructure program that's been described today? And is it true that you've also asked the SIU to extend its investigation into possible corruption in that arena? Then the second question, you released the second expenditure disclosure report on the 1st of October. Thank you for that. The Treasury is not here today. One of the things I picked up in that report was an amount said to have been spent of 196 million rand on wooden flooring for a tent here at Chris Hani Baragwanath Hospital. Now, I clarified that with the Department of Infrastructure Development, and they said that it is an error. And yet that figure of 196 million rand still appears as the leading expense in the overall list of expenditure by the province. And I just ask you to comment on it, one, whether you're aware of it, but secondly, whether it doesn't suggest a cause for concern that the Treasury is putting out a report that could be inaccurate by about 190 million rand in the total figures that it gives for expenditure in the province. Thank you.
Okay. Yep. Griselda, you want a second bite?
Good afternoon. Thank you very much. Criselda Lewis from SABC Television News again. Premier, I'd like to ask you, do you know if any of your family members have benefited from the supply of PPEs to the Gauteng Department of Health? Brother-in-law, sister? I'd like your comment on that, please. Thank you.
Okay. All right. Okay. So.
Premier Pulali Treaty from ETV News. Premier, you've just sacrificed your prodigy here in this matter. Is this also a sign of some sort of political weakness? Because we're getting sources as well, or rather information as well, that this decision, despite the SIU report, was politically motivated as well. Thank you.
Okay, thank you. It was politically motivated. The decision to Can you just repeat your question?
Premier Pulali Treaty from ETV News. You've just sacrificed your prodigy here, and of course your suggestions that you're looking into the SIU report, but most importantly, we're getting information from sources within that this decision was also politically motivated. Was this a sign of some sort of political weakness, because pressure was mounting for you to act, Premier? Thank you.
Okay. All right. Those are the questions. I'll read a few that we've also received on the WhatsApp line. This one is from Arisa from Network 24. We just got the news that MEC Bandile Masuku has been demoted. Well, I think this was done before the announcement, because clearly the Premier, the Premier's announcement was very clear. There was no demotion. I don't even know what that means. Greetings, this is Sinesipo from Record newspaper. My question, do you know when the hospital visits will be allowed? Second one, those implicated in wrongdoing in the SIU report of the COVID-19 tender procurement, what steps will be taken by the provincial government? I think also that the Premier has made it clear he has been acting on the referrals. And the next question says, I think from the same person, will Bandile Masuku stay on as a member of the provincial legislature? I think that question, to be fair, should not be directed to the Premier, but rather to the party that is responsible for the membership of the legislature. Then there's a question still from Network 24. Can the Premier please explain on the constitutional duty which the SIU says Masuku failed on? Okay. I think those are the questions the Premier will be able to answer, but those that were directed at health, like when our health visits, hospital visits are allowed, I suppose the acting HOD can answer that. Should we get the acting HOD to answer first, Premier? Okay, HOD?
Thanks. The question that relates to visitations, you'll recall that we are still under level 1 of the COVID response. There are institutional arrangements that have been made to ensure that, of course, the critically ill and injured patients were without necessarily adding to the risks that they could be revisited. We are also still in discussion about, given the fact that we are dealing with the decreasing number of daily infection, how best to coordinate the dignity in terms of the patients being visited vis-a-vis the minimizing the risks of exposure. As the Premier and the colleagues have said, that the virus is not gone, so there are still control mechanisms that relates to the vulnerability. As you recall, that patients that are actually in facility are the most vulnerable under the specific conditions. So patients could be visited as agreed at an institutional level based on institutional needs and arrangements. Thanks.
MEC Mutara will answer the question from Daily Maverick.
Yeah, we did respond to it, so I'm just looking for the
No, otherwise the Premier can speak and then
Find it. MEC Mutara will mark part of your question. I would like the MEC for infrastructure to deal with it. And then there are other parts that have to do with our Department of Finance, and I'm definitely concerned about the issue, but let me get the MEC to respond first. Griselda, you asked when I informed MEC Masuku that he is discharged from his responsibilities. What did he say? I can't discuss matters like this, what I have discussed with someone who was entrusted with the responsibility of public office and who, at this point, a determination I have made is that I must discharge them. I can't really go into details, including what his intentions are as it pertains to those issues. Anyone who would be facing a process like that must take it seriously. When you are faced with, you have to face a process like that where there are allegations of this magnitude that are, and the investigations relating to you. All I can say, I'm sure the former MEC will speak for himself about any issues about, I can't say what is it he's going to do and so on, because that has basically nothing to do with what we are doing. You should remember that the SIU is continuing to investigate PPE corruption. There are several follow-ups they are making also on the companies. So we relate to them as an institution of state in that regard. I also want to confirm, Mark, that there are also infrastructure-related issues that they are investigating. In fact, it's not just infrastructure. We said everything related to COVID. You remember the COVID response included even food relief. We said if there are any allegations related to our COVID response, all of those, the President has done a proclamation on the SIU investigations, which is wide-ranging. But to me, every time there's an allegation that arises, it may include any other issue about an infrastructure project or a particular procurement. I'd say the SIU must look at that. So I can confirm that they are doing that, and I'm confident that where there is wrongdoing, they will be able to act. But the provincial government's overall objective that we needed in our response to COVID, we needed to link what our medium and long-term plans on infrastructure, health infrastructure. On that, we were very determined. We think we are still correct, that we said, how do we use the opportunities of a pandemic on the plans that may be delivered only 5 years or 6 years later? How do we use the opportunity of a pandemic to jack up this infrastructure, to go to a place where the hospital would have been closed, where there may have been a hospital that was decommissioned and go there and give it a facelift. Or go to a place where there was no hospital, such as an old hospital owned by the mining company. They were no longer using it. And we say we want to upgrade it. Those intentions are good. To come to Chris Hani Baragwanath and say you have had lots of pressure, Bekim Langeni, as a district hospital, is under pressure. You also service Kopanong in the Val, which is under pressure, to say we have always had intentions to upgrade Lillian Ngoyi into a district hospital. That as a goal, as a policy objective, we said instead of going to put up many in stadiums and in warehouses, put up temporary facilities and spend lots of money, 6 or so temporary hospitals. We said, let's direct most of this money into the existing facilities, existing health hospital complexes. Yes, there may be issues about things that must be repurposed based on the clinicians and the feedback from the hospital CEOs to say, maybe with regard to that, we must think about post-COVID. When COVID is gone, we must start doing that now, because we may not need so many ICU beds or critical care beds. But the infrastructure that we have built and the technology that we're bringing in, how do we improve the existing hospital complex? So that was the Gauteng government's approach. Was it wrong? Should we have just rushed to go and build temporary hospitals in different areas and at the end of that dismantle all of them? History will judge us, hopefully, correctly, to say the focus on improving existing capacity was the right decision. The focus on also in the process on bringing ABT was the right, so that we build faster. But there are always things we could do better. Consultation with the people who are in charge of these facilities, so that when the designs and the purposing and everything is done, we must accept we are a democracy. And in democracies, we run processes through consultation. The input and the feedback of the specialists who are in charge of our hospitals, that is critical. It's a non-negotiable. The hospitals are currently looking at, Mark, they are looking at beyond COVID. How do they integrate these facilities into their day-to-day normal operations? I have said, I'm giving this an okay. Yes, it is the right time to start doing that right now. Even as some of these complexes are being completed, where we are done, get the hospital that is responsible there to do that. But where corruption may have happened, there should be no mercy. Because when you make the right decisions to do something that benefits the public, and in the process something wrong happens, you can't blame yourself for having made those decisions that you must do something that is aimed at improving the quality of life. Correct processes must be followed. One of the things that frustrated me a lot was just how long the procurement process was taking. Because the Department of Infrastructure Development kept saying to Mark, even if it is about responding to COVID, we must follow the procurement processes. And I kept saying, but when? And then the second thing, I get frustrated with the disruption of projects in this province. Every building of a school, a clinic, or even houses, hospitals, they get frustrated by what the people call business forums. So a lot of our projects are also delayed. Can I blame government officials on those? No, I will blame government officials and business people on other things. I can't blame them on things that there have been lots of disruptions in the upgrades. I know George Mukari, there were many occasions where a full week they couldn't work because there were a group of people saying their business forums were putting unrealistic demands about this project. But I will have no excuse for corruption. So if there's something wrong that took place, it must be dealt with. I am only talking on the basis of an official report of a state organ called the Special Investigating Unit. Am I aware, earlier this morning, I was made aware that there is a report that is released by a well-known private investigator, Paul O'Sullivan. I was made aware of that, but I work on reports that are commissioned formally by state institutions. So have I looked at that report? Yes, no. I've not looked at it, but I was made aware that that report was released this morning. But you've got to understand, Crisilda, that you've got to work on the basis of the reports that have been tabled formally. You need to understand that at the moment, I am acting on the basis of the report of the SIU, which had a recommendation that said I must take action. And I am convinced that even though there's area of work outstanding about their investigation pertaining to establishing whether the MEC was involved in acts of corruption or collusion, even though that's, and I am very interested in that part. I gave them this feedback in a meeting with them even before they submitted. I gave them the feedback. I am very interested in that part of the report as well. So someone's already saying, why are you reinstating? I'm not reinstating. I'm saying it would be, there are precedents in political systems across the world. Some of the people who are sitting here, if someone is removed from government, and I would like to act in consideration to the fact that the issues that are facing us are very, very serious, and that we as the leaders responsible for making decisions need to make decisions firmly and with conviction. But if someone later is not found to be on the wrong, it is not unusual, especially if you still have parts of the investigation that's going on. It's not unusual. I'm saying there are ministers elsewhere in the world or secretaries of particular departments. It's not unusual that should he not be found guilty on the matters of corruption and collusion, it's not unusual that I will consider reappointing him. It would not be unusual. But I am also saying to you that there are different areas that we consider. And I want to say basically that if there are areas of administrative oversight, if there are areas where errors of judgment, you can't treat those with the same seriousness with where there has been, whether it's official. That's why even with the disciplinary processes that we're having, where it is established that someone was deliberately trying to mislead, steal money from the authorities, or someone in the course of their responsibilities, they didn't quite adhere to all the things, but it is someone who gave it their best, so they didn't steal. The point I am making is that investigation will be very important for me. I think the question about, at the moment I have discharged him, and I've used the word discharged. Discharged is very important. You discharge someone from their responsibilities. The clinical people here use discharge differently. I'm talking in a hospital. In a hospital, you discharge someone when they are well. But in the army, you discharge someone when there is something that you have identified that there's something that has gone wrong. What is the degree? What is it? If there are still other things to establish, that's what will finally inform. So I have been asked by the SIU, if you can, the SIU says, Premier, you must make a determination about whether Dr. Masuku's suitability to hold office as the MEC for Health. That's what, and I've said, I have made a determination on one part, but when the SIU has completed their investigation, I will make a full determination on the rest. But it's not political. I don't know what you mean by politically motivated. It is not politically motivated. Oh, the gentleman who spoke about politically motivated. Where are you, sir? Yeah, he didn't want a reply from me. You can see. I don't know what he means by politically motivated. When you make decisions about appointing people and disappointing them or discharging them, you make a full consideration of the facts before you and what is in the public interest. What is in the public interest? The full consideration of the facts before you and what is in the public interest. So these issues that pertain to not having failed in his, having failed to comply with the Constitution, the PFMA, those issues are fairly serious issues. But even with them, you can always determine in exactly in which area did he do something deliberately, or in which area he did not do something that he was supposed to do. I'm saying when you look at that, things that are called political accountability, they are important. That's why I can't come today and say to you, I have looked at the SIU report and I'm doing nothing about it. I can't say that to you. But I'm saying I'm also waiting for the part of the SIU report which is of great interest to the people of this country and the people of this province. When that part is done, I will be at peace to know the truth. So I think Priscilla is talking, you're saying any of my family members, and now you're saying any, I have made it publicly clear in a statement. I issued a statement. There were several allegations made about somebody who bought cars, who bought me a car, and I made it clear that I don't know the fellow. There were follow-up allegations made about my wife was involved in PPE procurement, and I made it clear that my wife doesn't do business with government, nor my children. So any of my family members, and then you're now saying, including, so you want me to go on a search. You want me to go on a search. I have made it publicly clear that my wife and my children, who I live with every day, who we have discussed these principles, that they just need to live with the consequence that I am a public office bearer. They can't do business with government. They must live with that the consequence. If any of them wants to do business, they must go into the private sector. And they've made peace with that. It's not easy, I can tell you. So, but if you start saying, so, but there are other people that you may know, you want me to go on a what is called wild goose chase. Now you say you are what in-law. So all I can tell you, my family, none of my family members does business with government. So if one day you find someone who you say, but Premier, this is your cousin. They did something. This is there's some way I can tell you that in my declarations, you know, we do declarations every year. In the legislature, we do declarations. I do declare. This is what my family members, my wife and my children, the declaration of interest, anything that we have, that's something that I declare. That's what I am required to declare. So, ladies and gentlemen, I think the question about whether MEC Masuku will still be a member of the legislature is something that will be directed to him and the relevant party, the governing party. I can't speak on his behalf. I don't speak on behalf of the ANC. So we are moving forward. I would like us to focus on the next few weeks are important. The modeling team indicated that the surge is something that we must never, the risk of the surge is here. Very, very high risk of the surge. I want the Department of Health, the officials in the Department of Health to focus on the job. I want us with our cities, city of Joburg, you are our epicenter. I want our cities to focus on how we go out there and mobilize quite significantly for ensuring that we never drop the ball. We can't drop the ball. We did extremely well, but you saw those graphs. A surge can sometimes be worse than what you have dealt with before. And that's why we don't want to rule out the work that is still being done on infrastructure. So thank you so much for this. We will continue to give you updates on these reports. When we get, next time I get another report, I want to be able to keep the people of our province informed. Fighting COVID-19 is something we must do. And things that went wrong because of corruption are things that must be dealt with. But you can't also conclude that everything that went wrong is corruption. And there must be where things went wrong and it's because of corruption. It must be clear. Where things went wrong because people didn't exercise their judgments and didn't apply themselves fully to their responsibilities. We must also not conflate that with corruption. And that brings us to the end of the engagements today. So thank you so much. Please wear your masks, even when they try to come out when you speak. People in the townships tell me that they also see media people when they talk, they are not wearing their masks. Thank you so much. Okay, I see there's still a hand there, Tabo.
We're done with
Okay, so there will be MEC to deal with Mark's question.
Wear my mask. Thank you very much. Premier, just to indicate that we did receive the same question from Mark in writing, and we also responded in writing. Just to indicate that the response from DID and the response still stands, that the amount of 196 million may be for other services. What was invoiced from and paid from the Department of Infrastructure Development is a total order of amount of 1.9 million, 38,727 rand and 50 cents, and that the Treasury report indicates the enterprise and the total amount paid, but it is not an amount against DID, but what DID has paid for is 1.9 million. We did also, I think what would help is if Treasury gave us the detail of what invoices were paid to the said service provider, from which departments, it could then help us clarify. But that was the response, and we still, if Mark, if you want, I can even share a copy of the invoice with you, so that you can even get clarity as to the breakdown of what we were paid for, the 1,950 square meter wooden floor. Thank you.
Okay, Evan, yeah, go ahead.
Thank you so much. It's Gauteng Whittles from ENCA. Premier, you're still saying that you will consider bringing back MEC Masuku if he's cleared of corruption. But you're saying that you find the violation of the PFMA serious, and also if it, and his inability to act in accordance, or his failure to act in accordance with the Constitution and execution of his duties is also quite serious. Why would you leave the consideration to bring him back if you consider these initial findings of the SIU so serious? And then, and Premier, I mean, you've already touched on the issue of you're not going on a wild goose chase with your family.
So why did I remove him? Why did I remove him if I didn't take this seriously?
No, I'm saying, why keep the consideration to bring him back if these violations are serious enough to remove him?
Yeah, but I am also saying, I'm putting it the other way around. Why would I remove him at the moment? Why would I discharge him if I was just thinking, I want to see the totality of the picture? I want to see the totality of the picture to determine the question the SIU says, determine the suitability for office. Because that's the question they had said. Even as I am still going to determine that with that, but I consider those things worthy of taking the action I have taken now, discharging him. You think this is not serious enough? It is, Kevin, just admit. This is very serious. Thank you. It's very serious.
Thank you, Premier. If you will indulge me, you've clarified that you won't go on a wild goose chase with your family. And the question was put vaguely, but I wanted to put it more directly so we can deal with it once and for all. Can you confirm whether Mr. Kingsley Tlo Butler is your brother-in-law, and whether because the records have shown that his company Bliss Pharmaceuticals received a 32 million rand tender, and when you say that your direct family has been made aware they must deal with the consequences of you being a public figure, do you believe when it comes to extended family that there would still be a conflict of interest which would merit them also being excluded from doing business with the state due to you holding public office?
Thank you so much. Is that what, Griselda?
That's correct, sir.
Is that what your question was?
Yes, yes.
Oh, okay, you were not here. I'm sorry. I am very glad that you are mentioning someone. Prof. Rudo Matiba is here. May know the people you are actually mentioning them much better. You're saying Kingsley Tobata. I'm saying I'm very glad that, because it's good that you mentioned people's names so that you can clear the air. I'm saying there's a professor here who's an intensivist who may know the people that you are talking about better than me. So say Kingsley Tobata. And let me say that, so Kingsley Tobata is not a family relation to me. So there is a church, what is it called? The PICC, where my mother used to go. And Kingsley Tobata's mother and father went to that church. My mother went to that church. That's how I met Kingsley Tobata. Kingsley Tobata is married. Kingsley Tobata is married to Connie, who's a pharmacist. And that's why I'm saying she knows these people better than me. Kingsley and Connie run some pharmaceutical business, because Connie is a pharmacist. They have run a pharmaceutical business. I know Kingsley, like I know many of the people. He's not a relation to me. He's a Tobata. There's no cousin. The wife is a Nesangani. Prof. Matiba knows these two people better. As a practicing health practitioner, may even know better what they do. So if someone is sitting somewhere in a corner thinking, we got him. We finally got him. We finally got him. We dug something about family, his family. But fighting corruption will be killed by people who do this. Let me tell you, Kevin and Griselda, fighting corruption will be undermined by those who think if you are in trouble, you must try and drag other people in your trouble. I want to send out a clear message out there that, and it has been done before. People throw mud at me. Premier is a friend there who got a tender of 100 and something, 40 million or so, PPE tender. And the truth always comes on the side of those who are innocent. So, Prof. Matiba, I know your hand was up for something else, but I know that you know the Tobata and Nesanganis way before I met them. So there's no cousin or something about me and Kingsley or Connie. The Connie is a Nesangani. They are the big chiefs in Limpopo, in Vembe. And I have no relation with the Nesanganis except that when you meet them, and family can become family because you have met. But you say about conflict of interest. Yes, so my children, when you say as family, because family can include brothers and sisters who you may not even have, even if you are born in the same family, who you may not even have influence over what they do. But as long as they know that, if they get involved in this area of fortunately, that's something also that the governing party is discussing, this issue about, but I am clear, Kevin, but if the fight against corruption must not be undermined by wild goose chase. So obviously, if you want to know how many people I know, I just know, Premier, Batu. I know a lot of people. Do those people do business with the Gauteng government that I know? Yes, there are a lot. And why shouldn't they? But do they get business from the Gauteng Provincial Government through following proper procedure? Not my wife, not when I became Premier, not my children. If you say, but the other Makuras, I only have one brother and one sister. And I don't want them to say, we saw you talking about us on television, that the whole world now knows about everything we do. But I can tell you that corruption is very serious. Mark, corruption is very, very serious. I refer to you because I know your activism, Mark. You can't undermine it by starting to look for things that don't exist. So the Kingsley that you're talking about is someone that Prof Mativa knows much, much better. As I say, Connie, I went to university at Teflu. I was a student there. The wife, Connie, was in the Faculty of Health Sciences studying pharmacy, but she was ahead of me. We never became friends. Actually, she comes from an area where my wife comes from in Limpopo. So the wild good chase, we got him, will not work, because the point I want to make is that, yes, there must be a distinction between someone failing to live up to the expectation of what the prescripts and appointed position says. It may failing to live up to implementation of everything, including monitoring and management. There must be a distinction between that and acts of corruption. That is a basic, simple thing. And the law, our legal processes would be able to establish that. If you, I mean, the HOD has faced disciplinary action, Prof. Lukele. Just on face value, is not the HOD, Prof. Lukele, is not someone I would, if you've got to provide evidence to me for me to believe that that man is corrupt. I'm giving you an example, so it's not a, but there are things that the investigation says he did not do as the head of department. He didn't do. So that's part of what the disciplinary process is about. So I can't conflate that with the fact that he committed acts of corruption. And there will be, in the course of being in government, there are many cases I had to deal with where the finding is that, no, the person, there was maladministration, malfeasance, they may even have been, people may have even died, like life as a demand. But you are able to establish that the motivation, the motive behind it included corruption. Or in some instances, it just included, it was not act of corruption, but it's wrongdoing, which may not be corruption. So we still have to act. We still have to act. But I'm saying, when you add everything together, I am waiting for a situation where I have a report, the final report from the SIU that makes me connect all the dots, see everything in its totality. To understand, I entrusted MEC Masuku with the responsibility to lead a department that was very damaged. Very, very damaged. To reconstruct and help rebuild a department that was extremely damaged. It is an act of trust. The public entrusted me with public authority. I I trusted. That's why I want to know that my MEC for Health, when all is completed, I want to be able to know, was there something that motivated him more than what has been presented before? And on that basis, I think I will reach a final conclusion to say, I think this is, I shouldn't have even appointed him in the first case. I can't reach that conclusion now. It is only fair for me not to reach that conclusion now. I think the Thabo, Prof wants to say something. I saw he wants to say something. Please say something, Prof. I will allow you, Prof. There is the mic.
Okay, can you hear me? I know you're not here to ask about our welfare. You were here mainly concerned about the corruption scandal. But we are your hosts at Bara. Not a single one of you has asked whether we're still standing after fighting COVID. You haven't asked how are we doing. You have been after the sensational news. But I just want to tell you we're still standing after serving the community. And I'm speaking on behalf of the clinicians and the nurses and support staff of Krisani Baragwanath Academic Hospital. And we have served the community. We have saved lives. We are still standing. That is what my father taught me. It's not how you fall, it's not how you fail, it's not how tired you get, it's whether you're still standing after it's all over. We are still standing. Please report that in your news clips. Thank you.
Okay, thank you very much, Prof. Matiba. I think we really have to end it here. I know that you still want to ask follow-up questions and follow-up. If we go on, we will never end. We'll continue to deal with those issues even outside of the briefing. But thank you very much. We really have to end it now. Thank you.